I'm Dr.Oomesh Shamloll from Mauritius. So this is how Mauritius Island is described as the Paradise Island. And a very famous British speaker, a very famous British writer once wrote that God created Mauritius first, then copied paradise from it. And if I'm here in front of you all, it's because even in paradise, we have acute coronary syndromes, we have patients of ACS, of STEMI, which obviates the need to have cath labs and to treat them. So the most dramatic way a patient can present, an ischemic heart disease patient can present, is in acute LVF or with myocardial infarction. And we all know, we have all seen throughout our lives how dramatic they can be. And this is a time where we need to be very fast and try to save the patient's life. So I'll be presenting the implementation of 24/7 primary PCI in public hospitals, what was our initial experience, and how it has impacted the lives of Mauritians and the health system as a whole. So I always put this slide first because this was the first primary PCI I was doing in my life, assisted by my mentors. So if we go to, according to guidelines, any guidelines, AHA guidelines, ESC guidelines, ACC guidelines, NICE, or any local guidelines, they all say only one thing, that in cases of STEMI, which looks like this on an ECG, earlier the culprit vessel is opened, better is the immediate, short-term, and long-term outcomes. Minute in MI means cardiac muscle. So every minute that passes by, we all know that there is a part of the heart which is dying, and we should be as fast as possible to save them. So there are two ways to open the blocked artery. One is thrombolysis, which is the medical management, and the second is PCI, which is the interventional management, where we do angiography and angioplasty to open the artery. So up till very recently, up till 2020, when I became the head of department of my hospital, thrombolysis was still used in most of our 5 regional hospitals for all patients coming with STEMI. Coronary angiography may or may not be performed before discharge, and the patient was put on a waiting list of coronary angiography, where a decision was taken whether to do PTCA, go for CABG, or for medical treatment. So if we go according to our guidelines for primary PCI, it is said that primary PCI should be offered if the patient is presenting 12 hours of symptoms and PCI can be delivered in 120 minutes. Or it may also be considered if the patient is presenting for more than 12 hours, but the symptoms are continuing and the patient is in cardiogenic shock. And if a stent is preferred, drug-eluting stents are preferred. And in patients who are in cardiogenic shock only, the culprit vessel is open, and those where the patient is stable, we can do multi-vessel disease as an elective procedure. So if we go according to NICE guidelines 2020, upon first medical contact with a patient of chest pain, we have 10 minutes to do an ECG and make the diagnosis. And in non-angiography capable centers, 10 minutes to do thrombolysis. And in PCI capable centers, angioplasty should be done within the coming 2 hours. Wire crossing should be within 90 minutes. So if a cath lab is available, primary PCI is a preferred treatment of choice because the artery is open under vision, so the chances of failure are very less. There is lesser risk than with thrombolysis, for example, bleeding. There is immediate relief of symptoms as soon as the artery is opened, and the ST segments resolves instantaneously in front of us. So before 1st September 2020, our cath lab used to be open from 9 to 16 hours. Streptokinase in the beginning, then tenecteplase were used to thrombolyze the patients. The patients were stabilized, and the coronary angiography was deferred before discharge, or patient was put on a waiting list for angiography. The cath lab used to be closed after 4 p.m. on weekdays, on Saturdays at noon, and on Sundays and public holidays, the cath lab was altogether closed. In cases of failed thrombolysis for rescue PCIs, we had to transfer our patients to other centers where cath lab was available, and that also depended upon the place and, of course, the mood of the doctor who was on call. Some patient passed away on the way before reaching the hospital, or some after coronary angiography. Minutes means muscle in STEMI, and precious time was lost just transporting the patient from one place to another. So this is the hospital where I presently work. It is situated in the capital of Mauritius, in Port Louis. I had a dedicated and very young dynamic team, but we were all inexperienced in terms of primary PCI. But one thing was common among us was like, we were all ready to take the challenge to start primary PCI on a 24/7 basis. So that team consisted of 6 cardiologists, myself, 2 consultants, and then 3 junior cardiologists. So since the past years, always all of our patients were thrombolized and no primary PCI was done. Even if the cath lab was open in the daytime, my predecessors, they used to thrombolize the patient, we stabilize the patient, and then before leaving, we used to do angiography and plasty. So on 1st of September 2020, the time when I took charge, so primary PCI was done right from the first day, at least from 9 to 16 hours when my cath lab was open. Because in Mauritius, we need to get the permission from the government, from the Ministry of Health, to open our PCI center, and that also we need to have the personnel. So on 26 June 2021, it took me around 8 months to get things right, and primary PCI on a 24/7 basis was started as a pilot project by Ministry of Health at Dr. G2 Hospital where I work. So right on the first day, I get a male of 40 years old, uncontrolled diabetes, smoker, who came with epigastric discomfort since last night, with central chest pain since an hour. He had a malaise, he lost consciousness. When he regained consciousness, he was brought to the hospital by his friends. He was in his site of duty, and he was unable to speak. And this is what his ECG looked like. So he was having chest pain since night before. So we can see the Q waves and ST elevations in the anterior leads. So the patient was straight away taken to the lab, and coronary angiography was performed. And this is what his right coronary angiography looked like. Nothing serious, it looks clean for a smoker and diabetic. So this is a left coronary system. We can very well see that the LAD is blocked right from the middle part. Just passing a wire opened the artery, and in no time, a stent was just slid there, and we opened the artery while direct stenting. And this is what we got as a result. The patient was completely stable. I'm sorry. That's the long axis of his echocardiography. And this one is a 4-chamber view. We can see there are some slight hypokinesia of the septoapical region, but the LV looks quite good. The patient was discharged on the 3rd day. He was reviewed in 2 weeks, stable, without any chest pain, and leading a normal life till now. So there are various advantages of primary PCI. To the patient, the artery is open under vision, so the chances of success is very high. Pain and ST elevation subsides as soon as the artery is opened. There is no thrombolytic use, so the risk of bleeding is almost 0. And the ejection fraction of the patient is preserved, so his personal, professional, and family life is preserved, and he's productive in all aspects. The days of hospitalization is, in most cases, is 3 instead of 6. And the number of medicines used are less, so the side effects to the patients are also very less. There is early return to the professional, personal, and family life, as damage to the myocardium is almost negligible. So advantages for the hospital and the system. The days of hospitalization is halved, the normal course, as compared to thrombolysis, so the bed turnover is simply doubled. 1 dose of tenecteplase in my country cost around 50,000 rupees, and a stent cost around 7,000 rupees when we buy it in bulk for the Ministry of Health. Thrombolysis leads to bleeding complications like CVA, GIT bleeds, so these can be fatal sometimes or cause serious handicaps, and all these can be straight away avoided. Heart failure in case of failed thrombolysis, which is around 30%, it adds up to the burden of cardiovascular disease and heart failure. Many medicines are used, and the expense and side effects to the patient is increased, and this leads to a vicious cycle where we keep on spending a lot of money. So our Ministry of Health, we have 5 different regional hospitals, and our Ministry of Health buys around 2,500 vials of tenecteplase or thrombolytic every year. And that amounts to around $3 million, which is a lot of money. One cath lab costs around 35 million rupees, and 3 labs can easily be added to any hospital just by doing primary PCI round the clock in our existing 3 labs. So the money saved can be used for other developments in the health sector. So of course, as any new technique, we have to get accepted. So we had our share of problem of implementation, acceptance, preparation of the team and the approval, anesthetists and radiographers, which are always rare birds in any part of the world, place to rest, mess, payment issues, etc. But after multiple meetings by the stakeholders at the Ministry of Health, all of them were settled and the program was started on 21st of June 2021. Initially, our vision was to, like every patient presenting with STEMI should benefit with primary PCI on a round-the-clock basis. Primary PCI can be extended to the other 3 existing hospitals and get one in the other 2 hospitals, get one cath lab in other 2 hospitals. So every citizen has the right to get the best treatment in case of STEMI, and that best treatment is no doubt primary PCI. So what is the actual state of affairs? Like after the tremendous success of initial pilot project at Day-2 Hospital, the Ministry of Health decided to extend the project nationwide. And since June, July of 2022, the other 2 centers of the island have also started primary PCI on a 24/7 basis. And patients from almost each hospital, especially those where cath lab is absent, are being transferred as far as possible to a PCI center for primary PCI, depending upon the CCU beds available. So a small spark that started at Day-2 Hospital has taken a nationwide dimension now. An introduction of primary PCI in our health system has brought a paradigm shift in the treatment of patients presenting with STEMI. And we can now say that we are at par with the latest mode of treatment as any developed country for STEMI patients. What better can we give to a patient who has come with this than this? Like, we can very well see the difference how it is. So in 21st/10 of 2021, CCU of the Day-2 Hospital were the only public sector to win the competition of African Kaizen Special Mention Award 2021. It was set up by the Japanese authorities. And in the middle, you can see he's our health minister. And on the right side, we have the ambassador of Japan with the team. On 6/10, 2022, in Singapore, Asian Pacific Society of Interventional Cardiology honored me with a fellowship and official board member of the society for the paradigm shift in the treatment of STEMI patients in Mauritius. And I dedicate this to the whole team of Dr. Day-2 Hospital and all those involved in the success story. And on 17th March 2023, we won the Public Service Excellence Gold Award with a prize money as stated. And we also won the National Productivity and Quality Excellence Award of our country the same year. And cherry on the cake was on 7th of April 2023, when European Heart Journal published an article that read, "Small country, big difference, how one physician's vision became a reality and transformed acute myocardial infarction management in the Republic of Mauritius." And I dedicate this to my senior cardiologist colleagues who toiled over the years, on which I added my small piece of brick of primary PCI, and all those who were directly or indirectly related to the project to make it become a reality. So in conclusion, primary PCI is an undeniable treatment of choice for STEMI cases worldwide, accredited by all renowned international guidelines since years, and it is the best gift that can ever be given to a patient presenting with STEMI. It has advantages not only for the patients, but to the health system and society as a whole. There should be a political and professional will to impose such decisions in the benefit of all and the health system. Mauritius has advantage of being a small country, and any corner of it is reachable in less than 120 minutes as recommended by all international guidelines. And after doing around 450 cases over 3.5 years, I can say our success rate is more than 99%. And primary PCI, though more risky, is easier to do than any other intervention, and is the only procedure that saves lives in ischemic heart disease patient in the immediate short-term and long-term basis. We have got a learning curve, and that learning curve has to be implementation of the 24/7 primary PCI has been the most rewarding progress in cardiology in the past 20 years in our country. And with this, I thank you.